Welcome to Health Matters, where we explore key topics from a primary care perspective. I'm your host, Dr. Sheylan Spencer. Here at Vandalia Health, we are passionate about bridging the gap between primary care and specialty medicine, ensuring that complex medical topics are accessible and understandable for healthcare providers and patients alike. In each episode, we'll dive deep into the latest advancements, best practices, and critical insights to help improve patient care. Thank you for joining me on this journey toward better health. Today, I'm pleased to announce that we have Dr. Braydon Dymm joining us. Dr. Dymm is a board-certified neurologist and accomplished physician who specializes in cerebrovascular disease and stroke care. After graduating summa cum laude from the University of Detroit University and earning his medical degree from Wayne State University, he completed his neurology residency at Michigan Medicine. Dr. Dymm recently finished an advanced fellowship in cerebrovascular neurology at Duke University Hospital. He has made significant research contributions with publications in respected journals like Neurology and Stroke. Currently, Dr. Dymm serves as a neurohospitalist in the Department of Neurology at Charleston Area Medical Center. His passion for advancing stroke care and medical education has established him as an emerging leader in the field. Dr. Dymm, thank you so much for coming and being with us today.
Thank you for having me. I'm excited to be here.
When you were not covering stroke call, what do you like to do for fun in your spare time?
Sure. I also love to play board games. I'm a huge board game aficionado. And actually, I recently published a board game that involves strokes and taking care of somebody with a stroke.
Kind of walk me through that. How did you come up with that?
Sure. So the anatomy of the cerebrovascular system, I look at it all the time, and I figured, you know what, this could be a board game map that you could move around. And so I co-created a board game with Dr. Zach London from University of Michigan called Circle of Willis.
Oh my gosh, what an amazing! Where can we find this game anywhere?
Yes, it's actually sold online. It is sold online at thegamecrafter.com, and there's also some information at nerdgames.com. That's NEURD games.com.
Oh my gosh! Well, thank you so much for sharing that with us. I'll definitely have to check that out. How long have you been here in Charleston?
I've been in Charleston for the last 2 years. I joined Charleston just after completing my stroke fellowship in June 2023.
Oh my gosh. Well, it sounds like you've been here for a couple of years. You're really helping advance our neurology department, and we're just so thankful to have you here. Today we have just a few cases that we really think would help our audience just kind of walk us through your thinking as a neurologist. If it would be okay, we'll just go ahead and jump right into the first case.
Sure, let's jump right into it.
Case number 1, we have Mr. J. He is a 67-year-old male with a history of hypertension and type 2 diabetes and obesity. He presents to the emergency department with sudden onset right-sided weakness and slurred speech. He reports that he has been primarily having these symptoms for the last few days. He was unable to come to the hospital due to lack of transportation, and he did not have access to a phone. His previous medications consisted of metformin and lisinopril, but he's not been filling these for roughly about the last 8 months due to the lack of transportation to and from appointments. His social history is positive for chronic tobacco use. He smokes roughly 1 pack per day. Vitals reveal the following. He has a heart rate of 83. His blood pressure is 182/100. And he's sat 95% on room air. His physical exam is significant for some mild right-sided facial droop. His speech is slightly slurred. Right arm and lower extremity strength is 4 out of 5 on the right, and left side is 5 out of 5. He has decreased sensation to light touch on the right upper extremity. Reflexes are 2 out of 4 throughout. He has a little bit of right-sided Babinski that's upgoing. Coordination reveals mild dysmetry on finger to nose testing.
Sure. So on that exam, what immediately jumps out to me is that he has some weakness all along the right side. And I have a saying that if you have sudden onset weakness on one side of the body, that's a stroke until proven otherwise.
Awesome. Well, in terms of next steps in diagnostic imaging, it seems like the emergency department got an EKG, which revealed normal sinus rhythm. He had a CT head, which was negative for hemorrhage. He had a CTA head and neck, which reveals no large vessel stenosis. Throughout his hospitalization, he had an MRI brain, which confirmed the presence of ischemia in the left MCA territory. Echocardiogram with bubble studies revealed no cardioembolic source. Additional labs revealed a hemoglobin A1C of 8.2. Lipid panel reveals an LDL of 122 and serum creatinine 0.6. So really, Dr. Dymm, whenever we're thinking about patients like Mr. J, can you just kind of walk us through your thought process in regards to next steps in management?
Yeah, absolutely. So the first thing that I've noticed is that unfortunately Mr. J is outside the treatment window for thrombolysis or thrombectomy. He came in after 2 to 3 days. I think, lack of transportation was an issue for him. If he had come in within the first 4.5 hours, he would be considered a potential candidate for thrombolysis, which has been proven to reduce disability and help people recover faster from a stroke. So our focus now shifts entirely to what I call secondary prevention. We're trying to prevent any further strokes or any further cerebrovascular events that could happen to him. A stroke has already happened, and now we can help him recover and try to prevent this from happening again. So really, I'm focused on careful evaluation of his risk factors and implementing guideline-directed therapies. So for most patients, that starts with antiplatelet therapy, blood pressure control, cholesterol management, diabetes care, and lifestyle interventions. I try to take a holistic approach.
I love that holistic approach. So let's just first start with antiplatelet management. What would you recommend for Mr. J?
Sure. So for somebody with a non-cardioembolic ischemic stroke, and by that I mean he had an EKG and that showed normal sinus rhythm, so there was no evidence of atrial fibrillation. He is presenting more than a day out from his symptoms. So in this case, the standard of care is a single antiplatelet agent, and this can be either aspirin or clopidogrel, the brand name Plavix. The choice really depends on patient factors like tolerance, prior side effects, and cost, but in Mr. J's case, I would probably start with aspirin 81 milligrams daily. I think that'd be appropriate and the cheapest option for him.
Thank you so much. It's such a great point. We often hear, especially in family medicine, about DAP therapy or dual antiplatelet therapy. When is that ever appropriate?
That's a great question. This comes up a lot. So DAPT therapy or dual antiplatelet therapy, this does have a role in secondary prevention, but it's in really specific cases. So there's a couple of trials that have come out that have proven for minor ischemic strokes or high-risk TIAs who present early, usually within the first 24 hours. In those cases, we can use aspirin and clopidogrel for a short duration, sometimes 21 days or up to 90 days based on these clinical trials, which are called CHANCE and POINT. So outside of that, though, the bleeding risk outweighs the benefit. So since Mr. J presented later with more significant deficits, he really would not be a DAPT candidate.
Thanks for clearing that up for us. We saw that his blood pressure was pretty darn high when he came in. Blood pressure was 182 over 100. What are some long-term blood pressure goals we're kind of looking at for Mr. J?
Yeah, absolutely. So the AHA actually just published brand new guidelines on hypertension, and previously it had thought that maybe less than 130 over 80 was a good goal. Now more evidence is accumulating to suggest that trying to keep it below 120 over 80 for most patients, provided that they tolerate it. Blood pressure control is actually one of the most powerful interventions that we have for reducing recurrent stroke risk. So definitely restarting that lisinopril. You can even consider adding a thiazide or calcium channel blocker, which may be appropriate. Equally as important is trying to make sure that he has access to care and his prescriptions, which has been a barrier for him in the past.
So I'm hearing tight blood pressure control is a must for Mr. J with a goal of less than 120 over 80. I feel like this is exactly where family medicine can kind of really help bridge the gap with neurology as well. We talked about lifestyle, or we talked about risk factor reduction. He had a hemoglobin A1C of 8.2. Does neurology have a specific target in regards to his diabetes control?
Sure. So we generally follow the ADA guidelines, and we generally aim for an A1C of less than 7% in most patients, unless there are some contraindications. And so for someone like Mr. J, who's still relatively young and without major comorbidities, a goal under 7% makes sense to me. And, I defer a lot of this management to the outpatient setting. This is something that we know and we check an A1C routinely in the hospital, but then we do defer it to his primary care doctor. This is kind of a longer term project to try to get this under control. And beyond glycemic control, we also look at which agents may reduce vascular risk, sometimes even GLP-1 receptor agonists or SGLT2 inhibitors in collaboration with primary care or endocrinology.
That's such a great point. So GLP-1s, SGLT2s, these can help reduce vascular risk. So these are definitely agents that we'll try to incorporate into patients coming in with TIA or previous history of CVA. Let's finish with lifestyle. When we're talking about Mr. J, what are some changes that he can make on a day-to-day basis?
Sure. So this is sometimes the biggest conversation that I have with patients. I spend the most time talking to them about this. I try to sit down in the room with them and try to have a deep conversation, because these are conversations that really change lives, right? If you can say, hey, you've had a stroke or you've had a mini stroke, and this is really a wake-up call to try to change some behaviors. So I break this down into 5 areas: smoking, sleep, diet, exercise, and alcohol. So the absolute number one thing here is going to be smoking cessation. Quitting smoking is definitely the single most impactful change that Mr. J can make in his lifestyle. This is so important. Smoking really accelerates the wear and tear on blood vessels. It makes them stiffer, more prone to clot formation. It's not just stroke risk, it's also cardiac risk and systemic risk.
Such powerful advice. So smoking cessation, I feel like this is really where family medicine can kind of help step in whenever it comes to helping reduce risk factors. Whenever we talk about sleep, what are some things that you recommend in regards to sleep?
Sure. Sleep is very important. We all need more sleep, I feel. And sometimes this gets overlooked. So sleep apnea is also very common in stroke patients, and if untreated, it actually increases the chance of another stroke. So this is not only a risk factor that leads to stroke, but it's also a comorbidity that develops after a stroke. So it's really supposed to be on the front of our minds, especially when we're following up, and we should be screening for this, asking about loud snoring, daytime fatigue, or witnessed pauses in breathing that can be screened for. And if this gets diagnosed, then the most important treatment is using that CPAP that can not only increase sleep quality, but also reduce blood pressure and stroke risk. This is one of those hidden risk factors that primary care teams and neurologists can work together on.
Wow. Oftentimes, this is one of the things whenever I see a patient come in who I walk through the door, you see, and their stop bang is going to be 3 or 4. I'm asking them, how are you sleeping at night? And usually further history will be like, well, my wife kind of mentions that I may pause in my sleep at night. So this is great to know that getting them the referral to sleep medicine can kind of help reduce blood pressure risk and the risk of stroke. What about diet?
Sure. So in terms of diet, I strongly recommend the Mediterranean diet. This is recommended by the American Stroke Association, and the Mediterranean diet really means building meals around fruits and vegetables, whole grains, beans, nuts, fish, and using olive oil as the main fat. It's not about perfection. Everyone slips on the diet. You go out to eat, but it's really about shifting the overall pattern. I often tell patients, if you could replace red meat with fish once or twice a week, swap butter for olive oil, and add a handful of nuts instead of chips as a snack, those small changes, if you sustain them over time, can actually build up and make a big difference in vascular health.
So we've talked about diet. Now let's shift over to exercise. What are you recommending to patients for exercise?
Sure. So, exercise can be really tough. It's really tough to work this into your schedule, and especially tough for patients with stroke who may have weakness. But however you can try to achieve that exercise, whether that's by, actually going to the gym or doing something as simple as walking around the block, the target goal is 150 minutes of moderate activity per week. That may sound intimidating, but then you can just break it down, right? That's only 30 minutes 5 times a week. So it doesn't have to be the gym, right? So just walking briskly, even active gardening in your backyard could count. So I really encourage patients to find something that they enjoy, because enjoyment is what makes activity sustainable. There's good evidence that exercise not only lowers blood pressure and cholesterol, but it really helps with mood and your cognition, and both of which are often affected after stroke.
That's so practical. So we've talked about exercise, we've talked about diet and sleep. What about things like alcohol?
Sure. So alcohol can be kind of tricky. So there's a lot of confusion around exactly what is the recommendation here. So what we know for sure is that heavy drinking increases stroke risk. So for most patients, I recommend limiting intake to no more than 1 drink per day, and ideally fewer. So for many patients with other health concerns who've already had trouble with alcohol, it may be safest to just avoid it altogether. The key message here is moderation, and if you're in doubt, you might want to just cut it back.
That's such a practical framework. 5 categories patients can remember, and I like how you emphasize small, sustainable changes rather than an all or nothing approach.
Sure. And do you have another case for me?
I sure do. I have Mrs. L. She is a 74-year-old female. She has a history of obstructive sleep apnea, does not wear CPAP, hypertension, heart failure with preserved ejection fraction, who presents to the emergency department with transient aphasia and some right-sided weakness. This resolved around 30 minutes ago. Her medications include losartan 50 milligrams and Jardiance 25 milligrams daily. Social history is positive for 3 glasses of wine nightly. Vitals reveal the following. She has a blood pressure of 148/88, heart rate of 78, irregular on telemetry. She's afebrile, and her BMI is 40.
And what about her physical exam?
In regards to her physical exam, it looks like she is fully oriented. Language is intact. No cranial nerve defects. Motor is 5 out of 5 strength in all extremities. Sensory seems to be intact. Coordination reveals normal finger to nose and heel to shin. On auscultation, you hear an irregular rate, irregular rhythm. You don't hear any murmurs, and there's no jugular venous distension. Her lungs, she's clear to auscultation. Extremities, there's no edema.
Okay. And then, so, I'm noticing here that on auscultation, there's that irregular rate, irregular rhythm. So I'm worried what we might find on that EKG.
Yeah, absolutely. That EKG is back. It shows an irregular rate and irregular rhythm consistent with atrial fibrillation.
And what about her head imaging?
Yeah. In next steps in the ER, it looks like a CT head is negative for hemorrhage. They did go ahead and get a CTA head and neck, which reveals no carotid stenosis. She had an MRI brain, which reveals a small embolic infarct in the left MCA territory.
Okay, so even though her symptoms had resolved, unfortunately, she did have a small infarct in that left MCA territory. And so that probably explains that right-sided weakness and aphasia that she presented with.
Yeah. So when we're thinking about patients like Mrs. L, we start thinking about anticoagulation in regards to from a cardioembolic source. Can you walk us through how does neurology kind of think about this?
Yeah, absolutely. So Mrs. L's case is a pretty classic example of what we call a cardioembolic stroke. So in atrial fibrillation, that irregular rhythm, it causes blood to pool in the atria, most often the left atrial appendage, and that blood can clot. And if the heart pumps that blood clot up to the brain, that produces a stroke. It's a blockage of blood flow leading to tissue damage. The most important thing here is that antiplatelet therapy, like we prescribed for the last patient, it really does not adequately prevent stroke in atrial fibrillation. These patients need anticoagulation to prevent strokes if they've had a stroke in the past.
So when we talk about anticoagulation, how are you deciding which agent is appropriate?
The main tool that we use is called the CHADS VASC score, and this has a list of risk factors including congestive heart failure, hypertension, age, diabetes, prior stroke or TIA, vascular disease. All of these things earn points, and the higher points you get, the more likely it is that you might have a stroke if you don't take anticoagulation or use something like a Watchman device. So Mrs. L actually scores very high. So her age of greater than 75 actually gives her 2 points. Being a woman adds 1 as well. She also has comorbidities of hypertension and heart failure, each adding a point. So that easily puts her into the high risk category where anticoagulation is strongly recommended. So for her, we always consider the benefits and the risks, but for her, the benefits, I feel, far outweigh the risks of bleeding.
So that brings us to the next point, that the next big question many of us face, DOAC versus warfarin. What's your take on that?
Sure. So for the vast majority of patients, a DOAC, which stands for direct oral anticoagulant, this is preferred over warfarin. These are drugs like apixaban, rivaroxaban, or dabigatran. These are not only easier to use, but they're actually safer. They can have lower rates of intracranial hemorrhage, and there's really no need for that INR monitoring. That is the bane of taking warfarin. You need to get that INR monitored very frequently. And there's fewer dietary interactions. For warfarin, you always counsel, some people counsel avoid leafy greens, but really it's sort of, if you do eat leafy greens, try to keep it a consistent amount. So warfarin can still be used in special circumstances. It's not completely gone yet. Patients who have mechanical heart valves or severe mitral stenosis might need to take warfarin still. But for other patients with non-valvular AFib, DOACs are the clear first choice.
So once we start anticoagulation, how do you think about rate versus rhythm control for atrial fibrillation itself?
That's a really great point. So from my perspective as a neurologist, stroke prevention is priority one. So anticoagulation comes first. Rate and rhythm control are more about symptoms and long-term heart health. They're usually managed in partnership with cardiology. So rate control, trying to get that heart rate down into a range which is normal from 60 to 100. Using beta blockers or sometimes calcium channel blockers can be a good first step. Rhythm control can be considered for patients with significant symptoms, despite good rate control, or in younger, healthier patients where maintaining sinus rhythm might improve outcomes. But regardless of whether we pursue that rhythm control, from my perspective, I'm always focused on making sure they get that anticoagulation if their stroke risk is high.
Are there any other key points we should be thinking about for Mrs. L beyond anticoagulation?
Yeah, absolutely. So from the case presentation, two big things stand out here. So calling back to that first case discussion, this patient has sleep apnea, and you told me she's not wearing her CPAP. So CPAP can be annoying, but it is the by far and away the most effective treatment for sleep apnea. And untreated sleep apnea increases blood pressure, and it can actually worsen atrial fibrillation, and it independently raises stroke risk. So getting her back on CPAP could meaningfully reduce her recurrence risk.
So you mentioned two big things that stand out. So we have sleep apnea. Is there anything else that you would consider as being like a big point to hone in on?
Sure. So, she mentioned that she drinks 3 glasses of wine nightly, and, that might be a nice ritual for her, helps her calm down and relax. But, from what we know from studies, that level of alcohol intake is actually a contributor to both AFib and stroke. So I would counsel her to cut back at the very least to no more than 1 drink per day, and ideally less, to try to seek support if reducing is difficult. Even modest reductions can lower her risk. So every step counts.
Dr. Dymm, that's so helpful. Just to kind of recap, Mrs. L's small stroke was likely cardioembolic from atrial fibrillation. We talked about anticoagulation with DOACs as the cornerstone of really secondary prevention. And while rate or rhythm control may be considered, stroke protection comes first. Addressing things like sleep apnea and alcohol intake are also pretty darn critical. This is a case where primary care and specialty care really need to work hand in hand.
Absolutely. That's a great way to put it.
Vandalia Health CAMC is proud to be an academic medical center, which means we're training and preparing future doctors, nurses, and other health professionals to deliver the highest quality care. Through innovative research, advanced learning experiences, and more than 20 residency and fellowship programs, medical professionals are elevating their academic journey at CAMC to bring you the best care. Stay connected with Vandalia Health for all the latest updates by liking us on Facebook and following us on Instagram and X.
Any other cases for me?
Absolutely. We'll keep them coming. We have Mr. R. He is a 59-year-old male who presents to the emergency department with transient right-sided weakness that he reports started early this morning. He reports that his symptoms lasted for about 30 minutes to an hour, but have since resolved. He is afebrile. His blood pressure is 151/70. Heart rate is 68.
Okay, well, I'm glad that his symptoms have gotten better. Hopefully, in this case, this might be just a TIA and not a stroke. So let's see. What did the head imaging show?
In terms of his head imaging, it looks like the ED CT head reveals really no acute abnormalities. They did get a CTA head, which also doesn't show any acute abnormalities. CTA neck does show 75% stenosis of the left ICA.
Okay. Well, now I have a suspicion of what might be going on. Now let's see. Did he have a stroke or was it just a TIA?
Well, his MRI brain shows no signs of acute ischemia.
Okay, great for him. And then what other workup do we have?
Looks like they also got a hemoglobin A1C. It was 6.5%. Lipid panel shows an LDL of 148.
Okay. So this is a classic presentation of symptomatic carotid stenosis. So you had mentioned that he had weakness on the right, and the CTA neck is showing 75% stenosis of that left ICA. So what we know is that a clot may have traveled from the left ICA to the left hemisphere, causing right-sided weakness. So this is a transient ischemic attack. And, I'm looking at this left carotid stenosis like it's a criminal. I think that this could be the problem here.
So in this situation, when would we start thinking about things like carotid endarterectomy?
Sure. So for patients with recent symptoms, and TIA is included in this, and anywhere from 70 to 99% stenosis, CEA has been shown to, in multiple trials, to significantly reduce the risk of recurrent stroke. It's most effective when performed soon after the event, ideally within 2 weeks. So a CEA is the actual surgery where they remove some of the plaque that exists inside the artery. There's an alternative to this, carotid stenting, and this is sometimes considered as an alternative for select patients if surgery risk is considered a little bit too high. But in most cases, CEA is actually preferred. The key here is a timely referral to a vascular surgeon, so the window of benefit isn't lost.
So once he undergoes revascularization itself, what does long-term management look like?
Sure. So long-term management is going to be looking at the underlying vascular disease. So I'm going to focus on aggressive risk factor modification. Again, it's all the same things: blood pressure, cholesterol, diabetes, and lifestyle. And most importantly, he should remain on antiplatelet therapy indefinitely, potentially even lifelong.
So whenever you're thinking about antiplatelets, how long would you consider Mr. R to be on antiplatelets?
So for Mr. R, lifelong single antiplatelet therapy is the standard. And like I mentioned, aspirin is the most common, but clopidogrel is an option if there's an aspirin intolerance. In the immediate peri-procedural period, some surgeons do use short-term dual antiplatelet therapy, that DAPT therapy, like I mentioned, but that can be individualized. If they do get a stent, that DAPT therapy is continued for a lot longer, potentially up to 6 months. But the big picture here is that once he's past surgery, he should remain on at least one antiplatelet indefinitely.
So you've kind of talked about antiplatelets. Can you kind of walk us through your thoughts about statin therapy? I think his LDL was around 148.
Sure. So we know from a couple of different studies that an LDL of 148, LDL here is bad cholesterol, that's going to be a little bit too high. And the first trial that proved this was called Sparkle. In that trial, they recruited patients who've had a recent stroke or TIA whose LDL was above 100, and they randomized patients to receive high-intensity statin with atorvastatin, 80 milligrams, versus placebo. And those who got the statin actually had reduced risk of recurrent stroke. So for me, that's good evidence to say that my patients should be getting medicine that can prevent strokes. There's actually another trial called Treat Stroke to Target, and that looked at pushing that LDL even further down. So that trial looked at pushing LDL at a goal of less than 70 milligrams. And so that's actually the goal that we use today. In that trial, they also added ezetimibe, 10 milligrams, to that high-intensity statin to try to push it down even lower. So the combination that I'm looking for is going to be a high-intensity statin therapy. This can include atorvastatin 40 to 80 milligrams or rosuvastatin 20 to 40 milligrams. And then if that LDL remains above target despite maximally tolerated statin, that's when I would add ezetimibe or even consider a PCSK9 inhibitor. Those PCSK9 inhibitors are really powerful. The problem with them is that they can be expensive and hard to get insurance to cover. But overall here, the main point is that lowering LDL is one of the strongest tools that we have for preventing recurrent vascular events.
That's excellent, Dr. Dymm. I feel like we covered a lot of ground today, really from antiplatelets to anticoagulation, to even important things like lifestyle changes, to even when surgery is needed. If you had to give our listeners 3 key takeaway points from today's episode, what would they be?
Sure. I'm going to highlight 3 things here. So as a stroke neurologist, every time somebody comes in with a stroke or a TIA, I'm thinking about why did that happen? Why did that stroke happen? Where did that blood clot come from? And then I tailor my prevention strategy to that stroke mechanism. So, we talk about how some people have atrial fibrillation and that can cause a cardioembolic stroke. We also talked about large artery stenosis, like that ICA stenosis. And these have different secondary prevention strategies, right? AFib is treated with anticoagulation. Large artery stenosis can be treated with surgery. And if there's neither of those things, then really antiplatelet is the way to go. So getting that right diagnosis matters. I wish lifestyle was perfectly enough to cover all of it. But as a medicine providing physician, I do trust the trials that show that medical therapy is needed in some cases, right? So blood pressure control, cholesterol reduction, diabetes management, all of these different things, these are the cornerstones for me as a physician across all stroke types. And then, I really want to get it out that, stroke is a field where time is brain and acting quickly really matters. So if a patient shows up to the hospital within that 4.5 hour window, we can treat with thrombolytics sometimes. If a patient shows up potentially within 24 hours with a large vessel occlusion, then we can consider thrombectomy. And if the patient is having this large vessel stenosis, then within 2 weeks, early carotid surgery with that carotid endarterectomy, that can also save lives and prevent disabling strokes. And the benefit of all of these procedures is highest when done soonest.
That's a fantastic summary. Thank you, Dr. Dymm, for sharing your expertise, and thank you to our listeners for joining us on Health Matters.
Thank you for having me.
Health Matters Today is a podcast recorded at Vandalia Health Charleston Area Medical Center Studios in Charleston, West Virginia. Hosted by Dr. Sheylan Spencer, directed by Dr. Amy Bruce, produced by Christopher Cobb and Jason Likens.